Today we will talk about differential diagnosis and biopsy. Now, the outline will be the examination, the general principles, and the surgical management of oral pathological lesions. Now, whenever we have any lesion that we are suspicious of that's abnormal, we try our best to go with it in the same protocol we do for any lesion. Meaning, always we give about 10 to 14 days of non-surgical management, meaning we give medications, corticosteroid gel, whatever it is, we observe it, give medications, and wait for 10 to 14 days. If there is a resolution, great. If there is no resolution, we need to take a biopsy. If I find it highly suspicious of malignancy, very reddish, very fixed, indurated, all of that, I'll need to go for biopsy. Now, before I go for that, I need to go for the patient. I need to take the history, the medical, dental, name, history. Now, we need to take the history of the lesion that's present right now. But before that, we need to know something that the patient would be afraid. Once we tell him that there's a lesion, he would be afraid. He would start to be worried, anxious. So we need to be careful. We try to go with a systematic approach always, how to tell the patient that there's a lesion, even if it's benign. So what do? We tell the patient there is some abnormal structure present, and I prefer to go for biopsy to make sure it's nothing serious, and maybe it's nothing serious, and maybe it's not. So we can catch it early on and deal with it properly. Okay? Okay, perfect. So we need to take the history of the lesion itself. When did it start? When did it begin? When did you first notice it? The location, because in the lateral border of the tongue and the floor of the mouth, these are highly suspicious of malignancy. Has the lesion changed in character and features? Has it become larger? Has it become smaller? Has it become fixed or indurated in the area? What are symptoms, systematic or local, with this lesion? Any historical event, anything that caused this lesion to appear. Now, when we have a lesion, we need to know what the lesion is. So we have some terms that we need to be familiar with. For example, hyperplasia, increasing the number of the cells. Hypertrophy, increasing the size of the cell. Hyperkeratosis, an overgrowth of the keratin. Keratosis, formation of keratin in a non-keratinic structure. Erosion, ulceration or shallow superficial ulceration. Dysplasia, abnormal development of cellular size. Macule, circumscribed, non-elevated. So it's just a patch, let's say, of different color. Nodule, elevated, solid and palpable mass. Papule, same thing, but it's small. So the papule is a small nodule. The nodule is a larger papule. Pustule, collection of pus in it. And ulcer, a crater-like, a depression in the tissue, a necrotic tissue causing this crater-like depression that's present. And so on. These are all the terms that we have. Now, dysplasia, as we said, it's abnormal cellular structure. So meaning there will be different characteristics of the lesion or the cells. So, in such case, there might be hyperchromatism, increasing the number of the size of chromatin inside the cells. This will cause an increase in nuclear to cytoplasmic ratio. The nuclear to cytoplasmic ratio will be increased, increasing the nucleoli, enlarged nucleoli, anisonucleosis, unequal sizes of the cell or the nucleus. Hypertrophy, enlarging the size of the cell. Ah, sorry. Now, hyperkeratosis, keratin formation, drop-shaped reed ridges, abnormal stratification, basal cell hyperplasia, anisocytosis, unequal sizes of the cells, increasing number of mitotic figures, pleomorphism, change in in multiple shapes for the cells. So here's the process: normal to hyperplasia to dysplasia to lesions. Now, we need to check also the lymph nodes. We have post-auricular lymph nodes, pre-auricular lymph nodes, parotid lymph nodes, deep and superficial cervical, occipital, supra, infraclavicular, submandibular, submental, mandibular, buccal, maxillary. Now, we need to examine them because sometimes we will find that this lesion, if it's in the lateral border of the tongue, it's very common to have some features of it in the submandibular lymph node. Now, the lymph node's function is to fight any local bacteria in there. They collect it, and the lymph node will be the site of the war, the site of the fight. So, usually, if there's any infection, it will enlarge in size. That would be painful. That would be enlarged, mobile. So that's how I will differentiate a lymph node enlargement due to infection, which is common with flu patients, common with viral infections, bacterial infections, and so on, or enlargement due to a lesion or cancer. Now, the lymph node would be larger, fixed, indurated, and painless. These features of any metastatic or cancerous lymph nodes. Now, the usual size of the lymph nodes is 1 centimeter, except for the jugular digastric, which is 1.5 centimeter. So I will need to remember these numbers. Now we need to see the location, the size, the pain, the fixation, and the texture. Sometimes you might need x-rays to check CT, CBCT, MRI, whatever it is. So for example, here we have a cyst due to the canine or the fore, whatever it is. Here, this could be ameloblastoma. In these two, these are squamous cell carcinomas. So always, I will never be able to know with these X-rays, because I might think it's ameloblastoma. It becomes cancer. If it's not, it's the opposite. So I need to be careful. So that's why we need the biopsy, to be sure. It's the main way to get a diagnosis. Now we need sometimes laboratory investigation, CBCT, hemoglobin A1C, serum calcium phosphate, alkaline phosphatase, urine analysis, kidney function tests, tumor marker tests, and so on. And of course, we need complete blood count to see the hemoglobin and the rest. So differential diagnosis, it's the level we reach when we gathered all the information, and now we want to know to call what the patient has, to tell the patient you have X, Y. So we have differential diagnosis, in which we have multiple possible diagnoses, for this case. So we try to tip them off one by one. We start to cross off these diagnoses as we go with the features of the lesion. So for example, like in this cyst, this can be radicular cyst, this can be residual cyst, this can be Dentigerous wouldn't be dentigerous because it's a cyst, but I will cut it off because I don't have an impacted tooth. So I will go in this process. I will gather all the possible diagnoses, start to cross them off one by one. Okay, this can't be this way because it's doesn't happen in this location. It doesn't look like this, and so on. And this differential diagnosis can be clinical, in which at the clinical features, radiographic as the X-ray, or laboratory according to labs and the histopathology. So biopsy. Now, biopsy it's the main way to get a diagnosis. It's basically we take a piece of the tissue and study it under the microscope to get an accurate diagnosis. Now, about 15 to 20% of leukoplakias and 100% of erythroplakias, they have features of dysplasia or frank malignancy. So, should I take the biopsy or refer it? There are some factors that I should take into consideration. Health of the patient. If he's medically compromised, not compromised, does he need a hospitalization, no hospitalization, and so on. Surgical difficulty. Is it accessible, not accessible? Malignant potential. Now, how to know? When to say that I should take the biopsy or should I refer the patient? If I have high suspicions of malignancy, preferably it should be referred. If there is in between, we can take a biopsy. But before referral to surgeon, usually I prefer that anyone who takes a biopsy to suture with silk or nylon. So we know the boundaries when the patient comes. We know the boundaries of the lesion. Because if it's vicryl or absorbable sutures, it will be resorbed, so we will not know the boundaries where it reached. But with the silk or the nylon, it will remain, so we will know, okay, this lesion was up to this part. Okay, so biopsy, it's a removal of tissue from living body for microscopic diagnostic examination. The most precise and accurate, and it's to determine the diagnosis. We have incisional, excisional, cytologic, and aspiration. So whenever we have a lesion that remained for 14 days without improvement with the local therapy, intrabony lesions that are enlarging, visible or palpable submucosal swellings, these are indications for biopsy. Rapid growth of a lesion, red, white, or pigmented lesions, fixed high risk areas of development of cancer, and so on. So, characteristics that will tell us that this lesion is highly suspicious include bleeding, including that it remained for more than 2 weeks, erythroplasia, redness, fixation, the lesion feels attached to the adjacent structure, feels fixed. Induration, the whole area, the whole tissues look fixed and firm to touch. Fast growth rate and ulcers at the time of examination. So, cytology, this is not usually done in the oral cavity, usually in uterine cervical cancers. It's unreliable because of false negative results are very high, and patients would be not very comfortable after the biopsy. We can have exfoliative cytologic examination. This is the type we talked about. Or we can have what we call brush cytological examination. Because we collect cells with a rotary wire, we collect the cells and we send them to the lab. It's non-invasive, cheap, covered in many insurance plans, and does not differentiate between cancerous and precancerous lesions. So if it's cancerous, if it's inflammatory, it will not differentiate. It will tell us there's something wrong. Now, incisional for large lesions. We remove a small portion of the tissue. And risky hazardous spaces in areas where we feel it's malignant, we go for incisional biopsy. Now, should I take a broad, shallow, or narrow incisional biopsy? And should I take it from the center or from the borders? Now, the center is usually necrotic. In most of the cases, it's necrotic. So we prefer to go for the margins of the lesion and take a narrow but deep incisional biopsy. So we collect the abnormal tissue, the normal cells as well, and we send them to the lab. So if we take a broad shallow, I will not take that much of the tissue and it will not tell me anything about the normal tissue underneath. Usually we take it with a wedge shaped. Now, excisional for benign lesions less than 2 centimeters, we excise the whole lesion and refer it. Now, if this, after the histopathologic examination, it was found out to be squamous cell carcinoma or whatever it is, we refer to the patient to the oncologist to take the CT to whatever plan he has. So we take 2 to 3 millimeters of the perinormal tissue around it, and this usually is a definitive treatment. Now, aspiration biopsy for soft tissue masses. For mass in the submandibular glands, salivary glands, for neck masses, we go for fine needle aspiration. Now we have two types: a fine needle aspiration in which we collect cells, or we collect fluid to know if this lesion contains fluids, a cystic or not cystic, a solid mass. Now the technique, usually we take and we give anesthesia 1 centimeter away from the lesion, stabilizing the tissue. Now, stabilizing the tissue is very important. We don't want any iatrogenic blade injuries. So always hold it with an instrument. Hemostasis, suction and high volume, incisions, wound closure, and handling of the specimen. So here, as we said, 3O or 4O black silk, so we know the boundaries. Now, to hold the lesion, towel clips, Adson forceps, Calasian forceps, or heavy retraction force sutures, they can be placed. Now, a negative should never be taken as a final assessment. We treat the patient, not the paperwork. If we suspect it's not benign, we go for another biopsy from another site. So, to manage any pathological lesion, we need to know that we have, if it's a cyst, or the procedures we have: inculation and curettage, inculation and marsupialization, all of what we talked about in the cyst lecture. We have excision of the lesion. We have resection. So, basic surgical goals: we want to eradicate the pathology and to rehabilitate the patient functionally. So, resection, just to revise, we have marginal, in which we leave the inferior border; segmental, in which we get the whole tissue with the inferior border of the mandible. We can have total resection like maxillectomy or mandibulectomy, composite with adjacent structures. So what decides the management I want to go for? The lesion's aggressiveness, if it's aggressive or not, like ameloblastoma. For example, ameloblastoma, we need 1 centimeter resection more than the lesion. So the boundary or the safe margin for me is an extra 1 centimeter. So if the lesion ends at the 4 or the 5, we go for the 3 or the 2 to make sure that this lesion we got rid of the whole ameloblastoma if there are any cells remaining. This is an ameloblastoma case, and the recon plate in place. The maxilla or the mandible, proximity to vital structures, the size, the intraosseous or extraosseous, duration, and so on. For example, whenever I see this feature, now we have what we call fibrous dysplasia. Now, fibrous dysplasia is replacement of the bony structure with fibers. So that's why it will give us this shape, like trabeculae, but it's not trabeculae, it's not bone, it's fibers inside. But here we need to take a biopsy to check it as well. Here, for example, we have a cyst. We need to inculate it. Sometimes here we might go for marsupialization, and then we can go for inculation once we have good amount of bone to support the mandible. So here, for example, we have a lipoma case. We took excisional biopsy for it and removed it, all of it. Here another case, whitish lesion in the buccal mucosa, suspicious. Excision and removal and sent to the lab. Here we have fibroepithelial polyp. These are the retraction sutures. We hold it around it, very deep into it, and retract it so we can know where we're cutting. And hopefully it's a good lecture and you enjoyed it. If you have any questions, I'm always available, and thank you.